And hello, ladies and gentlemen. I'm here answering from my office, so from the Institute. I was just with some patients, and there's still some patients downstairs in the office, but I went to the conference room to be with you and to go through this live session and to see how I can enlighten any questions or comments that have developed since you've started this online residency program. So I will go to the questions that I have. I have here the questions from today. So the question is question number 1. What's your opinion on the zygomatic and the pterygoid implants? And a follow-up question to that is, how manageable are the complications from your experience? So let me separate that question into 2 parts. One is the zygomatic implant, and the second is the pterygoid implant. So the pterygoid implant is pretty much like an almost normal implant that we place into the normal jawbone. So it's the only difference is that it's placed, far back in the posterior, and it usually has a length which is about 15 to 18 millimeters. So it's kind of going direction let's say your ear. You can almost scratch your ear, so to speak. The zygomatic implant is a totally different animal, because the zygomatic implant is going, let's call it like the canine or premolar area, and it's going outwards towards the zygomatic bone, which is here. So it's kind of going lateral, and it's really coming pretty close to the suborbital space. And those implants can be, 25 millimeters, plus or minus a few millimeters. So they're double the length of a pterygoid implant. And a pterygoid implant, of course, is maybe, 50 to maybe 80% longer than a regular implant. If you take a regular implant being somewhere between 8 to 10, 13 millimeters. So let's talk first about zygomatic. Zygomatic, to me, is a very valuable solution for a particular patient group, which is like the elderly. Elderly, of course, is an abstract number. Maybe, let's say, 65 plus and older, maybe 70 plus and older. Because we basically can give 2 options to the patient. Number 1 is they don't need a full maxilla reconstruction, which of course is a big advantage in the elderly group, which may be also underlying medical conditions. And the second advantage of it is, if we do the zygomatic implant correctly, we're dealing with that you can temporize them immediately on the same day as implant placement, because you're going to have 2 implants on the right, 2 implants on the left. So you can have this cross-arch stabilization that we can do. Now, there's a lot of limitations of this procedure, because obviously, if you do 2 normal implants in the front, and you do 1 zygomatic on both sides, that's pretty normal. But you still have to have some bone width. So surgically speaking, it's a very challenging anatomy. So, for example, in my office, when I do zygomatic implants, I always invite one of my colleagues who has been trained specifically in the maxillofacial region, and also who has experience with these zygomatic implants, to do the case, the surgical case with me. So that's what I prefer. I've seen surgical experts in implants like myself also do this, alone in their office, which I think is totally fine if you feel comfortable. But I'm somebody who kind of recognizes that if there's somebody out there who has more experience, and I, of course, trust them, and I feel that they have good clinical skills, I prefer to invite them to work with me together, so we can put our experiences together and give the patient a better result. So that's what I do in my office. Complications of this particular procedure can be wide-ranging, because sometimes you go through the sinus, and sometimes you break the bone crestally, so you can have implants being exposed. And I guess the worst-case scenario is really that you have to remove these zygomatic implants, and then you have to do a primary soft tissue closure, because you can't really graft these cases then afterwards, because there's often sinus perforations. So it's a challenging treatment solution. So definitely it's for the advanced implant surgeon, and I would say even more for the expert implant surgeon. So that's towards the zygomatic. The pterygoid implant is more like a normal implant. It's just like difficult to get all the way in the back, sometimes depending on the mouth opening of the patient. But I've done pterygoid implants for 30 years. I just don't use them that much because the positioning of the implant is so at a tilt that, prosthetically speaking, it's difficult to manage them. And I prefer sometimes just to go a little bit more anterior and then do like a small sinus lift, open window or closed sinus osteotome, and then place normal standard straight up implants, then going all the way to the back. But, if you have a lot of bone in the pterygoid area and you have a very clear line where the sinus stops and you can enter with a pterygoid implant, it's certainly a treatment option. Complications of this particular implant are not really biologically so big, because if they don't integrate or if they show bone loss, we basically remove them. But if they fail or show bone loss after we made the bridge work for them, it's difficult to manage them, because the bridge often crosses from canine all the way to pterygoid implant. So it's a long span. So if they lose the posterior implant, they have no teeth anymore all the way in the back. So then you probably will have to have a secondary procedure, which is a sinus lift, and then 1 or 2 extra implants, probably 2, so you can make a bridge work for them. So how often do I do pterygoid implants in my office? Probably not that many. Overwhelmingly, we'll do a sinus lift with some implants. So those are questions that I got first on this particular topic. We have in the residency program some lectures on zygomatic. So of course, I recommend you to review that again. And some of them are really great experts in the field of zygomatic. Okay, so that's the question on this. Should I give you a moment to digest this and then see if there's any follow-up questions from you?
And Sascha, you definitely see all the questions further down on that. hopefully, if you're looking at the email I sent you today.
Yeah, I see more questions. So
Okay.
I'm just like waiting for
Some feedback.
yeah, like if there's a minute, I give a minute for feedback on this one.
Sure.
Okay, if there's no further feedback, we can always come back. Second question, which also came in today. If the patient has a high SMILE line during all-on-4 surgery, what are the options to do if bone reduction hides the transition line, will result in no height of bone needed to place implants, less than 6 millimeters? Okay, so that's a question which is a solid question, and it can happen pretty easy. So at this moment, of course, that for me is a contraindication for an all-on-4. So the way I would manage this case then is to really kind of look at it very carefully. Again, I would do a software planning of the implants with already like a bridge, a temporary bridge in the software planning as well. So we can see the teeth, the margins, the free gingival margin. And then probably you're just going to leave the bone as is because there's no vertical loss. And then we're going to do like a horizontal augmentation if bone is missing. And we're going to just do like a normal crown and bridge work. Normal crown and bridge work could mean, let's say, 8 implants, 6 to 8 implants, where like, you know, many cases we have solved like that, where we place 4 bridges of 3 units. So the patient has 12 units, and then the implants go into first molar to first premolar. So that's a 3-unit bridge. Canine to central with a pontic in the lateral. That's again a 3-unit, and then we cross the other side. So I would solve that in that matter, but I would not, like, you know, try to place shorter implants here. Any comment or question here? Okay, everybody's still pretty quiet. So then let me jump to the previous questions, and I'll go and this one continues the same trend. So the question is, if I work on an edentulous maxilla with adequate bone in the posterior, can I put 2 vertical implants there instead of 2 tilted in order to make an all-on-4 fixed prosthesis? Yeah, so I think like it's, well, the first answer would be saying absolutely yes. I don't see any problem with that. But the second more specific answer is that, you know, you're going to have to look a little bit into like how far, if you want to just place a straight implant, which obviously would also be my preference. So the abutments are easier to manage. Prosthetically, it's easier to manage. How far back can you go? Because in the maxilla, you really should not do a cantilever more of 1 tooth. So if you can go with your straight implant to, let's say, second premolar, and you have at least 10 millimeters of length there, or you can be maybe between first and second premolar, then we're good. We can just do normal straight implants, which would be my preference. But if you're normal straight implant, you know, the only location that you have is to go with an implant in position of the canine, then, like, you know, you don't have enough support posteriorly for your implant bridge work. So then I would prefer to do a tilted implant so you can get more posterior with the head of the implant. Okay, so that is this question. Any comments here?
Sascha, there is a chat message. I'm not 100% sure if it's related to what you've already spoken about, but they ask if the patient have an IAN very close to the crestal bone, what is the success rate of block graft? I did a case one time with my professor, and it failed not long after.
Yeah. I mean, this is part of like an IAN. You're referring to the mandible. Of course, this is a very specific region. I would say that most mandibles also have a missing horizontal component. So it'd be like, a vertical bone atrophy or loss and a horizontal bone atrophy or loss. So a block graft, I'm sorry to say, not surprised that it doesn't work or has not worked in that area, because as we know from block grafting, it's a really challenging biological system for new blood vessels to grow into, because the block grafts are so cortical and are so dense. So there's one treatment option today, which is scientifically followed, and there's one surgeon who has been promoting this here, is Fuad Kuri from Germany, and he puts like some microplates vertically and horizontally, like almost like he's building like a Lego small freeway or a castle. And I've tried that over the years, and it's not really that, biologically speaking, it's not impossible, and he has shown nice results, but it's just technically, so surgically, very challenging. So that's, I'm not surprised that when I look at the literature, it's always, like somehow related to his group who's publishing something. And that's the nice thing when you compare the block grafting with particulated bone grafts and membranes, so basically the GBR protocol, you see that today there's so many clinicians who are publishing on this here. It's not just me or Massimo Simeon or Danny Boozer, but it's like so many. So it's a biological better system, GBR over block grafting, and technically or clinically speaking, it's much more controllable than using a block graft. So I would always choose a GBR, particulate bone graft with a membrane with primary closure over a block graft. Okay?
And I think there's a follow-up question to that, Sascha. And then there was another Dr. Moyes who wanted to ask a question, I think possibly related. Dr. Ahmad, maybe turn on your mic and ask your question.
Hello, Dr. Sascha.
Hello.
Hello, nice talking to you. Just regarding the same topic, I just want to know what's the research on this new technique that you told about the German doctor, because I never heard of it. And the second thing is, so in your opinion, when you are faced with such circumstance, the best thing is a GPR with a membrane, even if like it's really atrophied, the ridge is really atrophied, and like you have like almost like a 2 millimeters to the perialveolar nerve.
Yeah. So, okay. To give you more options to like learning, there is material available in the scientific publications, which is under the name of Khoury, so Khoury. So that's covering that particular technique, and he has been using basically this technique of I call it microplates. But as I said, it's very technically challenging. But you can look it up under his name. And then GBR, GBR, of course, the less bone you have, like any other challenging type of bone augmentation, the more complicated it gets. So if you're only 2-3 millimeters away from the nerve, you have to really trim the membrane very carefully, and you have to place the bone graft very carefully, and then you have to also, of course, release the flap around the nerve, so there's no tension when you close the flap in this very challenging area. So it's not easy, but looking at the experts we have in the field of GBR, pretty much all of us who started with this technique 30 plus years ago, we started in the posterior mandible. So we have seen a lot of vertical augmentation success in the posterior. You can also look at some of the lectures in the guide library under the name of Marco Ronda. Marco has shown really some really good results, and he's a former student of Massimo Simeon, and he basically does the same work like Massimo. So you can look at that work, and you can also look at the work of Istvan and Istvan Urban, and Istvan was a student of my group, and you'll also see him work a lot in the posterior mandible. Also he presents really beautiful results. Okay.
Thank you, Doctor.
Yeah, and Dr. Jovanovic, this is the question from Dr. Moyes regarding the question about the transition line and smile line. If you want to approach the case as 4 separate bridge, how do you temporize it if the patient wants immediate teeth?
Yeah, so you could, in a question like this, if the implants, of course, are not getting grafted. So, if any of these implants that you're placing straight in the maxilla get a bone graft, so GBR grafts, then of course you have to use primary closure. So then you cannot use the permanent implants as immediate loaded implants. But if there's no primary closure necessary of the implants, then you can just use the permanent implants as long as they have good stability. Now, as an alternative, which I've also done for many years, and which works, is I use mini implants, mini temporary implants to stabilize a denture that the patient probably has, or to stabilize a modified denture. So that works as well. Okay. So I'm going to go to a follow-up question here, which was sent in, and it has to do a little bit also with GBR, so it follows what we just talked about. My question is when to use resorbable versus non-resorbable. Is the non-resorbable titanium reinforced membrane used when you try to avoid a full flap with advancing it to get a full closure in bony defects? So so if I understand the question correctly, it's asking, can you use a non-resorbable membrane when you do not want to try to close the flap completely for a bone defect? And the answer is no. For a good result with non-resorbable membranes, is you need to do a primary full flap closure. And that follows then, like, the first question that you have is when to use resorbable, when to use non-resorbable. So resorbable usually is used for the smaller to the intermediate bone defects. So it could be extraction sites, could be smaller horizontal defects. And the non-resorbable one, we use more for, for the intermediate to large defect. So that's kind of, the division that we have today. I just have to charge my computer. 1 second, I'll be right back. Okay. I'm gonna have to go to another location. Okay. Paul, is there another question? I have the questions from which were sent in.
Right, and there was another in the chat that I can read off to you while you're moving. The question was related to the nerves, on the topic of nerves. When performing horizontal particulate GBR technique on the mandible, if you put too much graft around the mental foramen area and maybe block it, can this cause paresthesia or nerve damage?
Yeah, that's a good question. And I have, I was kind of expecting that question a little bit. I have seen, of course, that it's pretty easy to actually have this particulate bone to migrate a little bit and then gets a little bit displaced. But if you don't do that really intentionally, and it's really just some particles, I have never seen, in my patients at least, partial numbness or some type of negative nerve reactions. So I don't see that really as a major drawback if that happens. Although I never, on purpose, try to graft around the nerve. I try really to stay away from the nerve by trimming the membrane carefully and using the membrane to isolate the particulated bone graft from the mental foramen. Okay. Now go back to the questions. Let's go to this one. When placing an immediate implant into a fresh extraction socket with a gap to the labial plate, do you use a membrane barrier to protect the bone graft? And if so, which one? Do you want to, choose closure, which can be difficult if it's a fresh extraction socket? Yes. Okay, so I think that's pretty clear, the question. So, and I just assume that, I'm going to assume that fresh extraction site means an immediate extraction site. So let's answer it like this. I actually just, before I jumped on this Zoom meeting with you, this live session, I had a patient come for follow-up after 2 weeks. So that's kind of, the way a patient would heal normally. So if I have a buccal bone defect missing, that's when I use a membrane. So then basically it becomes a full-fledged GBR ridge augmentation. And I'm going to augment the buccal. And I'm going to cover the buccal bone graft, which is, of course, on the implant surface. And I'm over-contouring. So I'm going outside of the bony envelope of the two adjacent teeth. I'm going to cover them that with a membrane. And this will be always a resorbable collagen membrane, like a native collagen membrane. Then primary closure. They need primary closure. So the question is, how do you close it? That's your question. So you have to release the flap, again, in the buccal-vestibulum. And when you release the flap by going through the periosteum, just very superficially, you can now advance the flap in such a fashion that, you can move it all the way to the palate and close that gap where the tooth was before. And then you'll suture it. And suturing will be the same thing, and kind of a non-resorbable PTFE cytoplast suture with horizontal mattress and single interrupted. And I just saw the patient. I don't have the photos yet because they took the photos while I was with you on the Zoom right now. But I saw the patient, and the shit healed really nice after 2 weeks. Now, if you do have bone, right? So that's also a question. So here it says that the labial plate actually is intact. There's just a gap. Then you can just use the labial plate as your membrane. It's a natural membrane. It's a natural biological membrane. And you just fill the gap with a bone graft material. So that's kind of, the way this works. If you want to close it, primarily for safety reasons, because maybe, let's say, you prefer submerged healing in the case, then, of course, you have to make a flap. If you just can keep it open, an open healing, because you have the buccal bone intact, you can do that too. Then you just graft the gap with a xenograft, and then I would thicken the buccal soft tissue in the gingival margin with a soft tissue graft from the palate. And I would place some kind of abutment, like it could be a healing abutment, could be a short abutment like an on-one, that gives you a transgingival healing, open healing, instead of submerged. So you then also don't have to displace the soft tissue margin. So the question is really just kind of, is the buccal plate intact? We do GBR and primary closure. If the buccal plate is, opposite. If the buccal plate is intact, we don't do GBR. We just graft the space, so the gap. And then we can, if we want to, we can keep an open healing. If the buccal plate is not intact, that's where we do GBR and do primary closure. Okay, so that answers this question. Okay, this one is interesting here. I have a question here. What is your view on using PEEK, P-E-E-K, as a screw-retained abutment? How did it perform clinically, any advantages over other abutment options. So my view is not really very strong on this here. I don't really use it in my office. I think most companies who started to sell it have stopped selling it. And the main reason that it entered the market of implant dentistry was just that the medical field with orthopedics was utilizing PEEK biomaterials in kind of low tension areas. And it just showed it as a good alternative as a biocompatible material. So as, of course, the implant dentistry field is always looking at new biomaterials, new products, they start to look at it too. And then, they realize that it actually, the soft tissue of the oral cavity likes the PEEK biomaterial. But it's kind of never really took off because it was difficult to prosthetically kind of get good fits. Also, maybe the tension resistance was not so good because in the mouth, of course, there was high tension. So I don't think that the PEEK is something that is going to be around for a very long time, and I don't use it anymore. Okay. Now, next one. What is the manufacturer of the bone scraper that you utilize to harvest autogenous bone? So that's the Italian company called Meta, and the scraper is called Micros, Micross, and this product is being distributed in the US by Osteogenics and in the US by Geistlich. But it's a company which is called Meta, and when you go on the guide homepage, on the industry partners, you'll actually see a button that you can click on, which shows you the Meta logo, and then you can get to the page, and then you could possibly contact them. But in the US, you can just contact Osteogenics or Geistlich. Okay. Next question. When is it appropriate to offer an immediate implant placement in the posterior area following extraction? And what are the criteria for making this decision? So this is a really like a question which is asking for a large answer, because there's so many options that are like, anatomical limitations that you have to look at. Number one, is there infection or granulomas? Then probably not good to place an implant. Is the buccal bone intact or not? If it's intact, you maybe can place an implant. If it's not intact, probably prefer to do a bone graft. Then, is the interseptal bone, so between the two roots, sufficiently thick that you can actually engage an implant? And then, and there's no real number on this here, but is the gap that's around the implant in, let's say, a molar area, is that still reasonable in distance? So when you put a bone graft in there, that it can actually close with normal natural healing with a bone graft? So when you put all these factors together, you can see there's probably more often not an indication to do an immediate implant placement than that there is. So I normally, and I've done some immediates in molars, maxilla as well, but my probably like 70-80% of treatments removal of tooth. Then I will clean the socket, often with the piezo surgery. And then I will do a socket graft only. And then 4 to 6 months later, I'll place and do the implant. Okay. And Paul, are we recording this live session?
Yes, we are.
Okay.
Yeah, so people will, it will be posted, just so everybody knows. It usually takes us more than a week at least to get these posted. That's because we don't just put it up raw. We try to make it look a little bit more presentable and edited. So, but all the questions that have been asked will be included.
Okay, perfect. Perfect. So you can review this also later. Okay, so let me continue with the question. There's still a couple of more questions here. Just have to find it again. Where are you?
And whenever you want, Sascha, there's actually also another question in the chat that I think might have been related to what you were talking about earlier.
Okay.
Just let me know when you're ready.
Yeah, I'm ready.
Okay. The question is, when do the periosteal release incision around the mental nerve on GBR cases? How far coronal to the level of the mental nerve you you place the incision, I think is what they're trying to say.
Yeah, usually about, when you look at the mental nerve, the incision will be about 5 millimeters away from the contact of the bone to the periosteum. And then, of course, you have to be extremely careful that you are actually not cutting too deep, because the nerve fibers can be right there, that you're just superficially releasing it. Okay, there's a question here. I have to read it. It's a little bit longer, but it seems to be something just kind of general. When an implant is in place, but you cannot tighten the cover screw because it turns in the socket, what does it mean for the outcome? Will we loosen it? What went wrong? Is it better to wait before we uncover it? This is like a day-to-day occurrence, right? So the implant, just like a normal situation. So what I would say today, because of the really enhanced and very advanced technology that the implant companies are using to produce a stable implant surface, you can pretty much feel comfortable that if you don't have too much torque on the implant, and too much torque could be anything even less than 20 Newton, that if you put the cover screw on it, you'll actually gain osseointegration or implant ankylosis within, I would say, 3 to 4 months. But I would always do a primary closure on that. So there's a submerged healing. And if you feel you can go longer with healing, like 4 months to 6 months, that should guarantee osseointegration. So if you have like what we call a spinner, like an implant which like rotates with your hands, you probably have a torque which is less than 5 millimeters, or less than 10 for sure. So just leave it there and, just wait. And I'd be very surprised if that spinner doesn't tighten up and get bone integration. Okay, so we pretty much went through all the questions. And I saw a couple of questions come in just now. So are they, I can't see them.
I can help. If are you talking about in the chat?
Yeah, I can't see the chat.
Oh, okay. Yeah, and if you don't...
Oh, here's the chat. Yeah,
Okay.
I can see it. Yeah. Okay.
And I think only the last question hasn't been answered yet. And I should just let everybody know at this point, yeah, I mean, if you've got other questions, you know, in the little bit of time that we have left, please, you know, enter them into the chat.
Yeah. So the question here is, that's again a good one, and it kind of gets part of treatment planning on everyday situation. What is your opinion about connecting implant and teeth for fixed bridge work? And of course, for me, scientifically speaking, that would be considered a high-risk treatment. So high-risk treatment means there's cases, and I have like a particular case which I follow up now for more than 20 years, which is doing fantastic. So there is an implant placed in second premolar, and I connected it with a bridge to the canine. And 20 years later, it's all as good as any other implant, which is doing really great. But it's high risk because the technicians have to be really, really good to give you that, you know, high marginal stability. Also, it depends on so many factors. How is the occlusion of the patient? How is the mobility of the tooth? So a canine is great because, of course, with a long root, there's very little mobility. So you're basically like turning, the implant is ankylosed, and the tooth has to behave almost like ankylosed because you don't want to have any torque on a bridge like this. So considering all these limitations and the high risk of this here, and also the high risk for prosthetic failure, so like, you know, screw loosening, fracture of materials, etc., it's usually better to plan 2 implants and then do, like, you know, an implant bridge versus an implant to tooth bridge. So try not to, unless you have to, and you feel that the case is good, try not to treatment plan a tooth connection to an implant. Okay, then Paul, I think we can close the session.
Yes.
And thank you all for being part of online education and training. I certainly have changed my modus operandus of communicating, but it's been, you know, under the circumstances, effective, and I hope for you too. So have a good rest of the day, and stay healthy, and we'll see you then in about 2 weeks, I think, or something like that, for our next live session. And that's our final session, right, Paul? The one.
Yes, exactly.
Okay. Yeah. So make sure that, like, you know, whatever you have either happening in your practice or whatever you have that you have learned in the residency program, that we cover that in there. Okay. A big bye-bye from Los Angeles. And I'm going back to patients because we're here at 2 p.m. in the afternoon. And see you soon.
Thank you, Dr.